Hello and welcome to this Mission Cure webinar. My name is Megan Golden. I'm the co-founder of Mission Cure, and I'm here with my colleagues, Dr. Lola Rahib, Shruti Mirashankar, and Sky Schrader. And I welcome you to this webinar on pancreatitis and bone disease. It's for people with chronic and recurrent acute pancreatitis and their families. And I also welcome our community of clinicians and researchers, some of whom are joining us today. A little bit about Mission Cure to begin with. My brother, Eric, and I co-founded Mission Cure in 2017 after he was diagnosed with chronic pancreatitis after a long diagnostic odyssey. Linda Martin, whose daughter Amy was also suffering from chronic pancreatitis, joined us soon thereafter. And when we learned after Eric was diagnosed that there were no approved treatments to stop or reverse the disease, and that his pancreas was inflamed and that it would just continue to get worse, that was just not okay. So we started this nonprofit, Mission Cure, to find effective therapies and improve patients' lives. And we're now 6 years old and have made a lot of progress, including helping launch some clinical trials of chronic pancreatitis treatments. We're committed to offering the community, the pancreatitis community, resources and educational content that has actionable information. And this webinar is part of that patient education program, which is supported by AbbVie. So thank you for that support. This topic is one that we ourselves are concerned about, and we've heard from a lot of patients about for a long time, and we're really pleased to be hosting this webinar. So I want to introduce you to our patient education project manager, Shruti Mirashankar, who will talk to you about our agenda for the day. A chronic pancreatitis patient herself, Shruti has brought a lot of experience, professional and personal experience, skill, and passion to our organization. So let me turn it over to you, Shruti.
Thank you, Megan. Our webinar agenda is outlined on this slide, and our topic for today is, can pancreatitis affect your bones? Today, we are exploring the connection between pancreatitis, osteoporosis, and bone health as applicable to pancreatitis patients. Why this topic? Well, life with pancreatitis is a journey filled with challenges. I know this personally. Usually, we face a mix of complications and other health issues in addition to pancreatitis itself. Sadly, these issues are often they remain unnoticed or are ignored because doctors and patients don't have access to specialized knowledge and up-to-date care information until it's too late. This inevitably affects our overall health and quality of life. One of these issues is how pancreatitis can impact our bones. Our aim for today is simple. We are here to help you understand the link between pancreatitis and bone health, stress the importance of bone care, and offer guidance so bone diseases don't sneak up on you. Our expert panel will shed light on this known risk and discuss ways to safeguard bone health and overall well-being. This information can empower you to make informed choices and improve your quality of life. Before we start, please know that this webinar will be recorded and posted on the Mission Cure website. You have joined in listen-only mode, meaning we can't hear you. If you have any questions, there is a Q&A option on your toolbar at the bottom of your screen. Please type them in the Q&A box. At the end of this webinar, our speakers will answer them. Now, let's welcome our first panelist, Dr. Darwin L. Conwell, an international authority on pancreatic disorders, an award-winning mentor, a professor, and a practicing gastroenterologist. He is the current chairman of internal medicine at the University of Kentucky College of Medicine. Dr. Conwell's deep passion for the digestive system, particularly the pancreas, has positively impacted thousands of patients and families. He will now introduce us to the connection between pancreatitis and bone diseases. Over to you, Dr. Conwell.
Thank you very much. I'm really excited that you all have chosen to join us in this webinar. We are really happy to bring this information to you. And I'm also very happy to welcome one of my colleagues, Dr. Rao, who's an expert in bone disease and bone health. And she's going to really educate all of us and explain this relationship between pancreatitis and bone disease. It's very important for you to understand this relationship and get the appropriate diagnosis and treatment as applicable to your individual case. Next slide. So we're going to cover pancreatitis and bone health and its importance, bone disease and symptoms, who is at risk and why, recommended screening and testing, prevention and treatment. And we're going to primarily focus on chronic pancreatitis today. Next slide. There are 2 million people per year who fracture their bones in the United States. We think about 25 to 40% of chronic pancreatitis may have some degree of bone loss. We know there are high-risk gastrointestinal illnesses, digestive diseases such as Crohn's disease, celiac disease, and cirrhosis of the liver that predispose you to bone loss. We also know that chronic pancreatitis patients have an increased risk for developing significant bone loss, and I'm going to briefly overview that with you today. The chronic pancreatitis patients have multiple risk factors that can predispose them to an imbalance in bone mineralization and remodeling and increase your risk of hip fracture. Most patients with chronic pancreatitis do not have hip fractures. I don't want to overly concern you or worry you, but it's important that we recognize there are risks associated with having chronic pancreatitis and we get you early diagnosis, get you screened and on to therapy. Smoking, vitamin D malabsorption that occurs because your pancreas is not absorbing fat-soluble vitamins, fat maldigestion, alcohol abuse, female gender, and chronic inflammation can predispose you to bone loss in chronic pancreatitis. Next slide. This is a study that from our PROCEED study from our NIH consortium called the CPDPC, that is a natural history study of chronic pancreatitis. PROCEED stands for Prospective Evaluation of Chronic Pancreatitis in Epidemiologic and Translational Studies. This shows a high prevalence of osteopathy, which is really bone loss, bone demineralization in chronic pancreatitis. And what this shows is that patients from 18 years of age all the way up to 75 years of age can have evidence of osteopenia, which means there's decreased bone loss, or osteoporosis, which is a more severe degree of bone loss. And female patients have more of this compared to males because of just aging, but also mostly the differences in estrogen in their bodies. Next slide. We published this paper several years ago looking at low trauma fracture in patients with chronic pancreatitis compared to those that have high-risk gastrointestinal illnesses. It is well known that Crohn's disease patients have a high risk of fracture, and we compared that to chronic pancreatitis patients. And what we found in 2010 is that actually chronic pancreatitis patients also fracture at a very high rate compared to Crohn's patients. So this is a risk, and we want to heighten your awareness of this, and we want to work on the evaluation, the diagnosis, and treatment if you do have some degree of bone loss. Next slide.
Thank you so much for sharing that information, Dr. Conwell. It's a pleasure to have you with us today, and thank you for educating our audience on the link between pancreatitis and bone health and setting the stage for us to dive deep into this topic. I now welcome our second panelist, Dr. Madhumathi Rao, a bone and kidney specialist with over 20 years of patient care experience. She is also a professor in the Division of Nephrology, Bone and Mineral Metabolism at the University of Kentucky Hospital. Dr. Rao will discuss bone health and diseases and provide valuable advice on taking care of our bones. A quick note to our audience, please type in any questions into the Q&A box and we'll answer them at the end of the webinar. Over to you, Dr. Rao.
Thank you, Shruti. That was a very kind introduction. And thank you, Dr. Conwell, for introducing the topic. I'm really excited to be here. And I think it's such an important discussion that we are having today to talk about bone health in patients with chronic pancreatitis. I think this is an area that requires a lot more focus a lot more dissemination of knowledge and a lot more awareness so that patients with chronic pancreatitis can comprehensively take care of their overall health. We can go to the next slide, Shruti. So over the next few slides, I'm going to cover bone health and its importance, why patients with pancreatitis tend to develop bone loss, what are the ways we test for bone loss, how we evaluate bone loss, and assess its severity, and then go on to talk about prevention and management of bone loss. So basically, this is not a new point that I'm making. All of us know that a healthy skeleton is important to maintain the balance of minerals in our body, because the skeleton is the repository of minerals such as calcium, phosphorus, and magnesium in the body. It's also a storage depot for protein and other nutrients in times of stress. Now, when we think of bone mass or the mass of bone in the skeleton through the lifetime trajectory, we know that there is an initial phase when bone increases in mass up to adulthood, usually about the age of 30 years, and then plateaus for a time, and then there's gradual loss. In women, this phase of loss can be accelerated after menopause and then continues into old age. Now, when we talk about bone loss, we are basically talking about what we see in the figure on the left. You see normal bone, and as bone is lost, you see thinning of bone. And if we lose more bone than we are supposed to in a lifetime, we end up with bone that is fragile and easily breaks under mechanical stress. So it's easy to see the lower image where the thinning of bone can predispose a person to developing fractures. So if we lose bone, one of the main consequences that we might deal with is the propensity to fractures as time goes on. Next slide, please. Right. So when we talk about bone loss, the two main categories of bone loss we refer to are osteoporosis and osteopenia. Osteoporosis is the most commonly seen type of bone disease. It's characterized by bone loss, as we saw in that figure. And because of the bone loss, bone strength is compromised, and that leads to an increased risk of fracture. When we talk about osteopenia, it's a milder degree of bone loss, but it still increases your risk for fracture. So when you start losing bone, your increase in the risk of fracture becomes a continuum that increases with the severity of bone loss. Unfortunately, bone loss is asymptomatic. You really don't know that you're losing bone until the point of a fracture. So we really need to monitor your bone density and anticipate the trajectory of bone loss so that we prevent fracture and decrease your risk for this. Few other ways in which we could detect bone loss could be that if you've already had a fracture and it's not healing, it might tell you that your bone health is not that good. The other way we might understand that we have ongoing bone loss is as we grow older, we develop spinal deformity and curvature, a term called kyphosis. We might often see older people with a bent over spine, and this is often reflective of osteoporosis. When we talk about osteopathy, it's a more general term, and it also includes a condition called osteomalacia, which includes soft bones, because these bones may not have a decrease in bone mass, but they have a decrease in mineral content. And patients with osteomalacia can develop bone pain, and this is especially important in patients with pancreatitis who tend to have decreased mineral absorption in their intestines, and this can lead to osteomalacia in patients with pancreatitis. Next slide, please. So, as we mentioned, patients with acute pancreatitis and chronic pancreatitis are at greater risk of developing metabolic bone disease. And as Dr. Conwell showed in his slides, the PROCEED study showed that the majority of study subjects, over 50%, showed evidence of osteopathy on their DEXA scan. We'll talk about DEXA scan in one of the forthcoming slides. And again, patients with osteopathy had a higher prevalence of fractures, both traumatic and spontaneous. Next slide. So before we proceed any further, it's probably relevant to mention the term bone remodeling. So bone remodeling is the process by which we turn over bone and renew old bone. So it's a continuous process where we break down old bone gets reabsorbed, and new bone is formed to replace the old bone that's removed. So as long as bone formation is adequate to replace the bone that's broken down, we are able to maintain bone health and strength because bone mass is maintained at the same level, right? So in a young person who has healthy bones, right, we do see that bone reabsorption shown by the osteoclasts, the yellow cells, right, is replaced by osteoblasts, which are the bone forming cells, right? And as long as the pace of those two processes are about equal, we maintain bone health. If you look at the lower panel, you see that there is much more reabsorption. There are many more yellow cells reabsorbing bone than there are purple cells that are forming bone. So when you have an imbalance like this, where the reabsorption is more than bone formation, you end up losing bone and bones become weaker and tend to break. Next slide, please. So having set the stage for bone remodeling, it's easier now to talk about why patients with pancreatitis are at risk of bone loss. The first issue in patients with pancreatitis, in fact, the most important issue, are the malabsorptive deficiencies of calcium, phosphorus, magnesium, and vitamin D. And we know that calcium, phosphorus, and magnesium are integral components of bone, right? So when we have a negative calcium and phosphorus balance, when we have a low blood calcium and phosphorus, and we have low vitamin D and magnesium, then the body compensates by increasing a hormone called parathyroid hormone. And this leads to a condition called secondary hyperparathyroidism. In this condition, to maintain the levels of calcium and phosphorus in the blood and in the tissue fluids, the parathyroid hormone actually leaches mineral from your bone and demineralizes your bone to maintain your blood levels, because you're not able to absorb enough of these mineral nutrients from your intestine. So at a glance, you're able to see that the dysfunction of one organ, the dysfunction of your pancreas, leads to a huge cascade of events that involve absorption in the intestine, vitamin D metabolism by the liver and the kidney, and resulting in low serum calcium, which stimulates the parathyroid glands, which in turn results in bone demineralization. So this is one of the central issues in bone loss in patients with pancreatitis. Next slide. But then there are other ways in which patients with pancreatitis might end up with bone loss, and those would be malabsorptive deficiencies of protein and carbohydrate. And we've talked about malabsorption of calcium, phosphorus, magnesium, and vitamin D. Apart from that, patients with pancreatitis often do not absorb adequate amounts of nutrition in the form of protein and carbohydrate, and that leads to protein calorie malnutrition with lean body mass wasting. And every time you lose weight, you lose lean body mass. And you might regain that weight, and that phenomenon is often called weight cycling, when you lose weight and regain it repeatedly. When you regain the weight, unfortunately, you end up regaining more fat than muscle or bone, unless you make a concerted effort to try and regain lean body mass. So in that cycle of weight loss and weight gain, you end up with a net loss of muscle as well as bone. And we should not forget the fatigue and reduced physical activity that patients with chronic pancreatitis experience, which again can lead to a decrease in bone mass. There are treatment-associated factors that can lead to bone loss. If you don't use adequate pancreatic enzyme replacement therapy, your malabsorptive deficiencies are not corrected, and the ongoing bone loss is not addressed. Right? Some people with autoimmune pancreatitis might be using steroids, which are not really good for your bones. They result in demineralization, right? And the increased use of pain medications decrease your physical activity and can contribute to bone loss as well. We should not forget the role of diabetes, because patients with chronic pancreatitis often have diabetes as a complication. Diabetes independently can cause a deterioration of bone microarchitecture. It can cause a decrease in bone formation, which is important to replace the bone loss that has occurred. And both these can lead to an increase in fracture risk. And then the other factors are inflammation in an inflammatory disease such as chronic pancreatitis. And then, of course, when pancreatitis is established in childhood, like especially children with cystic fibrosis, it can also affect your sex hormone levels, and sex hormones are really important in the skeletal development. Next slide. Okay, so I know this can be a lot to digest, and I've thrown a lot at you, but wait, there is hope, because knowledge is empowerment. And when we understand these issues, especially when we're living with a chronic disease, we end up tending to manage them better. And with more information, we are more empowered to understand what are the next steps we need to take to preserve our bone health and prevent further bone loss. So in the next few slides, we'll go over how we test for bone loss and what we can do to prevent and treat bone loss. So one of the most commonly used and probably best screening tools for your bone mass is a DEXA scan or a bone density test. What is bone density? Bone density, also called bone mineral density, reflects the amount of bone in our body. And generally, as a general rule, bones that are denser tend to be stronger, less likely to break. How do we test for your bone mass? We use a DEXA scan to test your bone density. And some DEXA machines nowadays come with another test called a trabecular bone score that gives us an idea of your bone quality. And then there are a host of specific blood tests which address other aspects of your bone health. Next slide. So one of the takeaways when we talk about a bone disease and pancreatitis is the question, should I check my bone density? And even before going for any further, I would just say, if you have recurrent acute pancreatitis or chronic pancreatitis, or you have one or more symptoms that we have discussed in this webinar, you should have your bone density tested. You should talk to your doctor to order the screening. And the next slide will give you a little more explanation about this. So the International Society of Clinical Densitometry provides a lot of guidance for who should be screened with DEXA. So if we look at that general guidance, it tells us that everybody, all women over the age of 65, all men over the age of 70 should be screened with a DEXA, right? If you're younger than those age thresholds, right, you should be screened with a DEXA if you have a risk factor for low bone mass. So what are those risk factors? Low body weight, if you've had a prior fracture, if you're using high-risk medications, or if you have a disease or condition associated with bone loss. And patients with chronic pancreatitis, cystic fibrosis, or the various etiologies of pancreatitis definitely fall into those risk categories. So clearly, it makes sense that anybody with chronic pancreatitis should be screened for their bone health with a DEXA scan. Next slide. How often should patients with pancreatitis have their bone density tested? So if you've already have established bone loss, if you've been diagnosed with osteopenia or osteoporosis, or if you are on treatment for bone disease, you should have a bone density every year. If your bone density is normal, or if you have mild bone loss that is stable, you can check your bone density every 2 years. On a general principle, follow-up bone density testing should be done when the results are likely to influence your management. Any other tests that are done for your bone health, their frequency would be determined by your doctor. Next slide. A few words about a DEXA scan. This is a really simple test. It is a gold standard test. It uses low-dose X-ray, and we usually measure the bone density at the hip and spine because these are the two weight-bearing joints and have the correct combination of compact and spongy bone, which are the two main compartments of our bones. It takes 5 to 10 minutes, and the information it gives us is really valuable, helps us determine the risk for fracture. How do you interpret a bone density? When you look at your bone density report, you might either get a T-score if you're older than 50 years, or you might get a Z-score if you're younger than 50 years. A T-score basically compares your bone density with the value of the bone density in young adults of the same sex and tells you how much bone you have lost since that young age, how many standard deviations you're away from that young standard. A Z-score tells you how much lower your bone density is compared to your peers, individuals of the same age and sex. So looking at T-scores, if you have a score between -1 and -2.5, you call it osteopenia. If it's lower than -2.5, osteoporosis. And if it's -2.5 or less, and you sustained a fracture, then it is called severe osteoporosis. Next slide. This is a test called a trabecular bone score, which has become more available in the last 5 or so years. It's a standard software now available on DEXA machines and reimbursed by Medicare. And it actually gives us an idea of textural bone quality in the vertebrae. And here you can see you have 2 patients in the upper panel and in the lower panel. And these 2 patients have the same bone density, but they have vastly differing bone microarchitecture. And the computerized or the digitized transformation of that bone architecture into pixels shows you the change in microarchitecture. And we are able to derive an index of this, which gives us an idea of your bone quality. Next slide. A bit about lab testing in osteoporosis. We run quite a few blood and urine tests in patients with bone loss. In the blood, we check calcium, phosphorus, magnesium, kidney function, alkaline phosphatase, which is an enzyme concerned with bone formation, your blood protein levels, again, an index of inflammation as well as nutrition, vitamin D levels, and we screen for other hematological conditions. We check parathyroid hormone levels as well as other hormones that may be relevant to bone health. We check calcium and phosphorus in the urine, and this gives us an idea of what your mineral balance is, how much you're taking and absorbing, and how much you're excreting, so what your level of balance is. We also have specialized tests that give us an idea of bone turnover, that is an idea of bone remodeling, how well you're forming bone, how rapidly you're removing bone. And like we mentioned, a balance of bone formation and bone resorption is the stable state, and patients with pancreatitis would have an imbalance of these 2 processes. Now, while these markers are extremely good for monitoring, they may not be so good for initial diagnosis, but we do use them in association with all the other testing to get a comprehensive picture of your bone health. Next slide. So, coming to prevention and treatment, one of the principles of treatment in bone disease is that you always want to identify treatable causes of bone loss and deal with them, intervene as early as possible so the consequences don't sneak up on you. So in terms of patients with pancreatitis, the first step would be correct nutritional deficiencies and optimize the calcium, vitamin D, and PTH axis. In this, appropriate pancreas enzyme replacement therapy to correct malabsorptive deficiencies is really important. Lifestyle is another important component of looking after your bones. Looking after your diet, protein, calcium, vitamin D, both through your diet and nutrition and through supplements is important. Introducing weight-bearing exercises into your day to improve lean body mass, muscle, and bone is important, at least 20 to 30 minutes a day, and avoid smoking and alcohol. Next slide. Treatment. So when we talk about treatment, we are basically referring to pharmacological therapy of osteoporosis or medications that can be used for osteoporosis. A basic principle is that you want to always correct deficiencies of calcium, vitamin D, and correct the PTH axis before you go for osteoporosis therapy, because you should use osteoporosis therapy on a clean canvas, right? You don't want metabolic disturbances before you start osteoporosis medication. So when do you start medication for osteoporosis? And your provider will consider medications if you have osteoporotic T-scores, if they calculate a risk of fractures. This is often called a FRAC score and can be calculated from your bone density and several other clinical variables. If this is elevated above threshold, your provider might recommend pharmacological therapy for osteoporosis. And if you've had the presence of fragility fracture, if you've already demonstrated that your bones might break on fairly low-level trauma, even if you have osteopenic T-scores, it would be an indication for therapy. Osteoporosis medications have an excellent safety profile, but as with all chronic medications, we have to monitor when we use osteoporosis medications. And based on the results of your testing, your provider will identify the best option for your condition. Next slide. The two main groups of treatments that we use fall into the categories of anti-resorptive therapy and anabolic therapy. We use anti-resorptive therapy when we detect that bone loss is excessive, and that is what is mainly contributing to osteoporosis. We would use anti-resorptive therapy. And if we detect from your testing that you're not making enough new bone, we would use anabolic therapy. So there are several options in each of these categories, and your doctor would choose the best one for you. But it's good to see that we are not restricted in terms of what our options are in treating osteoporosis. Next slide. Right. So the bottom line really is that you want to detect these problems early. Timely detection, diagnosis, and treatment can have long-term impacts on your health and quality of life to maintain your functionality, maintain your independence. We talk a lot about bone loss in the later years, but we should not forget that pancreatitis is a condition that can affect all ages. And we really need to also focus on bone formation during the early years. And this helps us reach a good level of peak bone mass. So focusing on bone health, not only in the later years, but building bone health in childhood and youth is important. You want to prevent bone disease with enzyme replacement therapy, attention to nutrition, physical activity, and by avoiding smoking and alcohol. Get screened regularly and seek early treatment for any bone disease. Next slide. So this is the website for the Bone Health and Osteoporosis Foundation. It is an immense treasure chest of information. It has a resource library. It has a lot of handouts and useful information on how you can look after your bones at every stage in life. So do check out this website for more information. Next slide. And as I close, I will thank you. This is our bone clinic, and we're very glad to make this partnership with Dr. Conwell's initiative for treatment of pancreatic diseases and pancreas research. We run a multidisciplinary bone clinic, and we look forward to seeing more patients with pancreatitis who we can help as best as possible. Thank you so much.
Thank you, Dr. Rao, for sharing such vital information with our community. It's reassuring to know that addressing bone health early on can positively impact our quality of life. And your insights, they offer hope, because pancreatitis patients can now talk to their doctors, get screened, and catch any bone issues early on. A quick note to our audience: if you have any questions for Dr. Rao and Dr. Conwell, please share them in the Q&A box and we'll address them shortly. I am now happy to introduce you to our final panelist, Rohit Sharma, our patient voice for this webinar. An IT professional in Chicago, Rohit has been living with pancreatitis and its complications for over 2 decades now. Rohit, your willingness to share your experiences aligns perfectly with our webinar topic. I'm sure your input will be really helpful to others facing similar challenges. Thank you for being here today. I'm just going to stop sharing my screen so Rohit and I can have a quick conversation as he shares his experience with pancreatitis and bone disease. Welcome, Rohit. Rohit, I think you're on mute. If you could.
Yeah,
that's great.
Thank you, Shruti, for introducing me, and such a great session you guys had for a patient who is suffering from chronic pancreatitis. And that's a real eye-opener for few people who have not gone through the bone disease yet, and I really wish they don't. So yes, I was diagnosed with chronic pancreatitis pretty early, and as you said, in '98, and after 5 years, I developed diabetes. But within this period, I had some relief from pain in 2000 when I was ERCP was performed over me, and that relieved the pain quite a lot. And I don't think I had the pancreatitis pain since then. Some of the reason was that I had to make some food choices, dietary habits, lifestyle changes. Of course, family had to accommodate a lot of it because a lot of change had happened. As you know, our diet, Asian diet, is quite carbohydrate and fat rich sometimes. So that was some of the modification that me and my family had to make. After the initial diagnosis of pancreatitis, I developed diabetes in 2003, after 5 years to be precise. And that I was prepared for it, actually, because the doctors made me aware of this, that you will develop diabetes because of the pancreatitis. And I was able to manage with the oral medications and the diet. Everything went well for some time. My weight is stable, no pain, nothing. I was able to travel, do my job regularly. But in 2009, I started losing weight and started having loose stools, the oil stools. I was not able to figure out what's going on. But my PCP back in 2003, knowing my background, referred me to a GI specialist for undergoing EUS. And that's when I was diagnosed with chronic pancreatitis. That was a formal diagnosis. I don't know how long I had it, but that is when I was diagnosed. And that was a little shock to me. That came with a lot of stress and anxiety I already had with my condition before, and I was able to stable, but this was a new thing which I had to adjust to. So because of this, I had to make some modification, not only in the lifestyle, but also in the job. Because some of the job I have to let go. I couldn't continue them because of, a lot of restrictions from the diet with this. That's quite a lot of to digest initially after initial diagnosis.
It does sound like a lot. Thank you for sharing so candidly. I did want to ask you, why does today's topic resonate with you, Rohit? If you can share a little bit about that.
It resonates perfectly and absolutely. I'm very happy that Mission Cure have had this session because of the fact that some of the patients don't really have the symptoms of pancreatitis. Like I said, I stopped having pain since 2000 after ERCP, and after the PERD therapy, after diagnosis of chronic pancreatitis, my weight was stabilized, and my stools were stabilized. There's absolutely no symptom, no pain, and I was able to do my activities. I was able to travel. I had a good travel job. But for some reason, I saw a GI in 2020, and he was a new GI because of my change in place. So he ran all complete panel on me. I mean, including not only the DEXA, he did the genetic panel on me to understand the cause of the pancreatitis. He ran the complete metabolic panel on me, the vitamins, and MRCP just to understand the baseline of the pancreas. And EPI. So nobody did the EPI on me if I'm malabsorbing. And then EPI and DEXA came positive. And that was a shock because I could not imagine I could have a bone disease with all my active lifestyle. And suddenly I was told that even a small jerk to your spine might break you because your T-scores are too low for your age.
You were 48 at the time, if I recall right.
Yes, I was 48 and my T-scores were minus 3.4. And for that age, my endocrinologist said, you are not experiencing symptoms because of your age. But as you will grow old, you will start experiencing symptoms. So good we caught it. They started the treatment. So that's why to answer your question, this topic is really, really relevant for the patients, especially for chronic pancreatitis, and especially with chronic pancreatitis and EPI. I would say this is a great topic which could be easily missed.
Thank you. Thank you for sharing your journey, Rohit. You're now under treatment for osteoporosis, and your doctors are reviewing how you're responding to the medication and your lifestyle changes periodically, and that's a relief. What advice would you offer our patient and caregiver community when dealing with pancreatitis and bone health?
If you're diagnosed with chronic pancreatitis, you should work very closely with your primary care doctor. And if you have a GI specialist, you should see them regularly. If you don't, you should see one as soon as possible so that they can evaluate you for various complications. Second thing I would say, listen to their advice. And repeatedly, our doctors here, Dr. Conwell and Dr. Rao, repeatedly said what lifestyle changes you need to make. Avoid alcohol, make healthy lifestyle, eat healthy, do regular exercise, do all that what they're supposed to do because they really help, because they help me. And then stay informed. This is the most important thing that pancreatitis patients should do because it's getting noticed nowadays, but 20 years back, it was almost unknown to some of the community. People would not know about pancreatitis. What is it? I mean, people know about, when you talk about pancreas, they know diabetes, but they don't know pancreatitis. So stay informed, do your whatever research you want to do, but don't over-research and don't make assumptions. That's another caution I would like to make. If you get some information, talk to your doctor and then follow their advice. And consult a specialist, other specialists if you need to, or when you are referred to. So those are the things I would ask the patients to.
That's great. Thank you so much. I truly appreciate you sharing your health journey with our community. I'm sure they'll find it valuable. I hear from Megan that we have quite a lot of questions on board, so we'll quickly jump into our Q&A section now. Megan, over to you.
Yes. Thank you, everybody, for submitting your questions. And I'm just going to dive in because I want to get through as many as we can. So we have one question from somebody who has EPI, or exocrine pancreatic insufficiency, and osteopenia due to bowel surgery for cancer. Is there a link between bone health and exocrine pancreatic insufficiency?
Yeah, absolutely. I mean, this is what Dr. Rao was explaining to us. And because you have chronic pancreatitis, you can develop exocrine pancreatic insufficiency. As the disease progresses, you can lose normal secreting enzyme cells that results in fat soluble vitamin deficiency, primarily vitamin D. But also there's other malnutrition things that can occur because your pancreas is not working very well. And this, of course, can lead to vitamin D, the hyperparathyroidism, all the things that can occur that lead to bone demineralization or bone loss or losing calcium from your bones. So it's important that if you have recurrent pancreatitis or have chronic pancreatitis, that you do get a baseline DEXA scan. And exocrine pancreatic insufficiency, EPI, occurs later as your disease progresses. If it does progress, everyone does not progress, but if it does, you definitely want to be on pancreas enzyme replacement therapy for that.
Thank you, Dr. Conwell. This is maybe not a bone health question per se, but why do people get pain in their backbone during pancreatitis? And this person said the left shoulder gets cramped.
Yeah.
The pain includes the
Yeah.
backbone.
Yeah, I don't have an answer for that. Dr. Rao, unmute yourself. I don't know if this is a metabolic phenomenon or not, but I've been treating pancreatitis for a long time, and I don't get a lot of complaints of back pain and shoulder pain, but maybe it's related to this. But Dr. Rao, any insights into that?
So again, osteoporosis classically is painless, and but we do see patients that complain of back pain when they have osteoporosis, and most of the time that's probably because, you know, as your bone weakens, your backbone is less able to support weight-bearing stress, and the direction of force changes as your bones weaken, as your vertebrae weaken, and possibly change in shape. And the change in direction of your mechanical stresses can give rise to chronic back pain. So this, if you are experiencing back pain, you should again talk to your primary care physician. Make sure there's no structural problem like a fracture or a disc problem. And if those are excluded, make sure, of course, like we talked about, get a DEXA scan and get a complete bone health evaluation.
And actually, this is something that we at Mission Cure can ask our pain experts about as well. I know pain for chronic pancreatitis radiates to the back, so maybe they have some insight into this. Next question, a particular drug. My doctor has suggested Evenity, if I'm pronouncing that right. I'm very scared of side effects. Is there anything I should be on the lookout for if I try this drug? And I had another question myself, which is, you said doctors will pick the best option drug for you. Can you say a little bit more about what the considerations are with different specific drugs?
Sure, absolutely. And thank you. That's a great question. And Ms. Elliott, thank you again for your question. I think that's a really important question. And I'll start with answering Ms. Elliott's question about Evenity. Evenity is a fairly new drug that has been approved by the FDA in 2019. And it has been shown to improve osteoporosis, especially in the spine, improve bone density by about 70%, which is a really big a jump in the level of bone mass. So it's certainly a very, very valuable drug that we have started using. The side effects that people are very aware of is the fact that during the trials, there was a slight increase in the incidence of stroke and heart attack. And when they dug deeper into that data, they found that these events occurred in people who had pre-existing cardiac disease or pre-existing cerebrovascular disease. So the medication does have a black box warning that if you do have underlying cardiovascular disease or cerebrovascular disease, there should be caution with its use. Having said that, the Evenity has otherwise been, very safe to use in most of the population, and is a very good drug. So if you don't fall into these high-risk categories, it certainly could be an option that you could discuss with your doctor. The other side effects that Evenity has are not very different from osteoporosis medications. People do experience things like bone pain, headaches, sometimes dizziness and palpitations. Usually many of these side effects are short-lived, and your doctor will observe you for any of these side effects when you start these medications. And to answer Megan's question, yes, so as an example with Evenity, for instance, if a patient has underlying risk factors, we would not use Evenity. In terms of other anabolic agents, say, for instance, Forteo and Tymlos, which also improve bone formation, we would not use it if a patient has suffered from cancer before or has had radiation. They're contraindicated. If they have a risk of high calcium levels, we would not use them, or if they have a risk of kidney stones. I would like to again emphasize that any of these osteoporosis medications, we should use them only when we've corrected underlying metabolic deficiencies, right? Because here you are modifying the process of bone formation and bone resorption. And if there are other things like mineralization issues going on because of pancreatitis, putting another drug into the mix is not wise. So you always want to correct the underlying problems before going on to these medications. Then there are other medications, which are the anti-resorptive medications. We usually look at things like renal function, dental health, as well as, make sure that patients do not have a low calcium before we start anti-resorptive medications. So your doctor should be looking at this checklist before they decide on what medication is best for you.
And just a follow-up, what kind of doctor does one go to for this?
That's a great question again. Usually people who specialize in bone health are endocrinologists or rheumatologists. We do have a few nephrologists for whom bone health is a passion. And at University of Kentucky, bone health is under nephrology. That's a little unusual, but you do see a lot of some proportion of kidney doctors who are very interested in looking after patients with bone diseases.
Thank you. Very informative. Okay, 2 more questions that I think you can get through quick, and then we have to turn it over to Skye and wrap up. One is, we've talked about recurrent, acute, and chronic pancreatitis. The question is there a connection between acute necrotizing pancreatitis and osteoporosis?
Yeah,
And
that's a great question. So necrotizing pancreatitis occurs when the blood supply to the pancreas has been lost, and actually you lose normal cells. The cells actually become necrotic and die. And so when your pancreatitis improves and you're over this this bout of acute pancreatitis, you have less normal secreting cells. So you can develop exocrine pancreatic insufficiency over time, and it usually occurs, months to years later. So it's not unusual that you may have a patient that had acute necrotizing pancreatitis that's very, very severe. You've lost part of the normal secreting cells, and you develop exocrine pancreatic insufficiency, same way you would develop it in chronic pancreatitis, where you lose normal enzyme secreting cells. So there is a connection there. The other thing I would say, I saw that question came from a female. So you also want to make sure you're also at increased risk just because of your gender. All right. So just make sure that you're getting DEXA scans and getting things checked just normally based on your age and gender. So for you, it may be a combination of necrotizing pancreatitis causing exocrine pancreatic insufficiency, and also based on your gender and age.
Thank you. And a good question to end on. Apart from diet and exercise, what other precautions should a patient take with regards to better bone health?
Dr. Rao.
Yes, I would say if you're smoking, try to come off that habit. Alcohol, the minimum that you need for social interactions, rather than making it a habit, would be advisable. And make sure that you openly discuss your bone health with your doctor at your visits, and talk about getting a bone density, talk about your results of your bone density, and talk about monitoring your bone health. So I think these 3 additions would be to diet and exercise as well.
Awesome.
Wonderful.
Awesome. I want to just say, I'm a gastroenterologist and pancreatologist, and I was just really so excited to get Dr. Rao in front of our pancreatitis patients in our community to really educate all of us, the gastroenterologists and the patients, on really the nuances of treating this disease. So thank you.
Both. Thank you both.
And I want to say thank you because for me, in spite of working with bone diseases for many years, this has been an education in itself in interacting with all of you and our webinar participants in understanding their questions and answering them. Thank you so much for this opportunity.
Well, wonderful. We hope you will continue to interact with us. And so that brings the program to a close, but one very important part still left. I want to turn it over to our Creative Communications Manager, Skye Schrader, to wrap us up.
Thank you so much, Megan, and thank you everyone for joining us today. On behalf of Mission Cure's team, I extend our sincere gratitude and appreciation to our panelists for their time, effort, and support in making this webinar possible. And thank you to Rohit for sharing a bit of your story with us. It was a pleasure hearing from you all. We post resources created for our patient community as part of our patient education program. Please subscribe to our newsletter on our website and follow our social media handles to access those. We invite you to complete a 1-minute survey after you leave the webinar. It will automatically pop up on your browser. Your response will help us create the resources you need and value. Registered people will receive a recording of this webinar, which we will upload to our website a day after the event. Our virtual door is always open if you have any questions or feedback. Thank you again, everyone, and we hope you enjoy the rest of your day.